Hi, good evening, everybody. I'm Steve Ford. I'm the Chief Executive at the Royal College of Occupational Therapists, and it's a real pleasure to welcome you this evening to our prestigious 2022 Elizabeth Casson Memorial Lecture. It's great that we can get together in this way, and I think one of the advantages of connecting virtually is that so many more people are able to join us. So it's fantastic that we've got a big crowd excited about tonight's lecture. And yeah, I guess if there's a downside that we can't see each other face to face, but we can still use the chat tab to connect with one another, and you can use the questions tab to ask questions to the Casson lecturer, as later we will have time for a short Q&A session. So I guess for many of you, this might be your first Elizabeth Casson Memorial Lecture. For me, it's my third, and really enjoyed the first two that I was able to hear and attend. It feels like a bit of a bonus, I think, with COVID getting the whole kind of synchronization of these lectures out of sync. It's meant that we've had a number of these in a few months, but we are now back into our normal pattern. So just a little bit of background. So the first of these lectures was held in 1973, and these lectures are set up in honor of Dr. Elizabeth Casson and the contribution, the massive contribution that she made to the occupational therapy profession. She was the first woman awarded a medical degree from the University of Bristol in 1919. And she then introduced occupational therapy to England, and in 1929 established the first occupational therapy school, Dorset House, in Bristol. And it's in recognition of Dr. Elizabeth Casson's commitment to further occupational therapy that we award the lectureship to an RCOT member whose peers consider them to have made and to still be making a significant contribution to the profession's development. So a real honor to be nominated in that way, and a real privilege for us all to hear the contribution of our lecturer. And so it was in her personal and professional capacity that Ying Hearn Heng, the clinical lead for pediatric OT at Ealing Community Partners NHS Trust Pediatric Occupational Therapy Service, nominated this year's lecturer. So I'd now like to invite Ying Hearn to introduce our 2022 Elizabeth Casson Memorial Lecture. Thanks, Ying Hearn.
Thank you, Steve. Good evening to you all, and thank you for this opportunity. Tonight will be one of the most special moments of my occupational therapy career, where I am given this honor of introducing to you the 2022 Elizabeth Casson Memorial Lecturer and my mentor, Dr. Sidney Chu. Sidney is seen by both professional peers as well as other colleagues to be someone who had made significant contributions towards the development of our profession. He promoted occupational therapy locally, nationally, and internationally through networking within and outside the profession, collaborating with various stakeholders, developing innovative service delivery models, enhancing performance and clinical outcomes, conducting research, sharing best practice and clinical expertise through talks, keynote lectures, clinical workshops, mentoring, and publication. Sidney began his OT journey in Hong Kong when he first qualified in 1982, and he continued on with his move to the UK in 1987. His thirst for learning, whether clinical or academic, is never-ending. This drive led him to obtain a postgraduate diploma in biomechanics in 1990, a diploma in the teaching of students with specific learning difficulties in 1992, a Master of Science degree in health psychology in 1995, and finally a PhD conferred by Brunel University London in 2005. Throughout his career, Sidney has made significant contributions to the OT profession. It is impossible to cover all his achievements here. However, Sidney's contributions were recognized when he was awarded his first fellowship by the Brunel University London in 2011, and second one from the Royal College of Occupational Therapists in 2016. I first heard about Sidney being an excellent occupational therapist and manager who led a pediatric occupational therapy service in the London Borough of Ealing from the clinical director at a Singapore private OT clinic where I was working when I first entered the profession in 2001. I subsequently heard more positive comments about him from fellow OTs in Singapore who had attended his training courses about how they felt inspired by his teachings and improved their practice. Sidney's name and standing in Asia and the UK, as well as within the international pediatric OT field, was high, and I felt inspired to work in the service led by him so that I could learn and develop my skills. In 2009, I successfully joined the NHS Ealing team and got to work under Sidney until his early retirement in 2014. In the 5 years under his leadership, he inspired myself and the team in continuously to develop our clinical skills and strive for excellence in clinical practice and service delivery. As a manager, he ensured that we had protected CPD time allocated. He led by example and often delivered trainings on topics either requested by the team or those he deemed beneficial. Sidney also ensured we all had regular support through both formal supervision and informal discussion. Whenever I had a query and needed his assistance, Sidney would make time to get back to me despite his busy schedule. His management of the team is efficient yet compassionate. I hold Sidney as the model of a good and effective manager, and this continues to be the standard I hold myself to after I successfully applied for his position jointly with another colleague in 2017. Throughout his career, Sidney has dedicated his time and effort in sharing his knowledge with other clinicians through the development and delivery of various training courses and publication of practice-based and research-based articles. I was fortunate enough to attend several of his courses. His teaching style is one which I personally found very helpful, as he has a way of organizing information and presenting them in a way which helped learners to make sense of the large amount of information within their area. Sidney facilitated learners to explore, then consolidate information both theoretically and practically so that they can then own the information and knowledge. Many participants I met through the trainings share similar views. I remembered an OT I had met in a Welsh special school who also attended some of his courses told me that Sidney is a guru for us children's occupational therapists. As a testament to his clinical skills, Sidney was well remembered by both peers and service users frequently when he was in the service as well as after his retirement. I was based at the Children's Centre when I first joined the service, when a nursery staff commented that she remembered him working with her about 20 years ago and how well he explained and demonstrated intervention strategies. More recently, a carer I was on the phone with told me she still remembered how Sidney helped her and her son, who is now a young person, to liaise with school where he advocated for the appropriate support he needed to be successful in primary school. As the leader of the service, Sidney was innovative and often a forerunner in service development and improvement. For examples, he introduced the use of the gas attainment scaling to measure the effectiveness of our clinical work before clinical outcome data became a key performance indicator set by the Commissioner. In 2009, Sidney redesigned the school-based service in Ealing by developing a 3-tier OT model of service delivery via collaborative working with the local education department, special and mainstream schools. This was not a model widely adopted yet in the UK. For many such joint initiatives within Ealing, and his legacy continues to this day beyond his retirement from the NHS in 2014. It is clear that Sidney's contribution to the world of occupational therapy spans across service management, clinical practice, and education. He has made a positive and lasting impact on many individuals, including myself. I know that a lectureship delivered by Sidney, with his passion for the profession, effective teaching style, vast knowledge grounded in research, and varied experience can inspire many more occupational therapists, especially the younger generation, who had yet the opportunity to work or cross paths with him. We as a profession need to treasure the passion and special talent we have in Sidney, and this lectureship is well deserved. I hope that through sharing Sidney's achievement tonight, it will motivate OTs, especially those from the BAME background, to develop their leadership roles in clinical practice, service development and management, teaching and publication. I now hand over to this year's Elizabeth Casson Memorial Lecturer, Dr. Sidney Chu.
Thank you, Steve and Ying Han, for the introduction, and welcome everyone. It is a great honor to present the 2022 Elizabeth Casson Memorial Lecture. I would like to thank my nominator, Ying Han, and the Royal College of Occupational Therapists for giving me this opportunity to share my experience in clinical service improvement to promote the practice and value of occupational therapy. It is always my passion to achieve better performance outcome for the service and better clinical outcome for the client, and that intervention provide are cost effective. The rise in health and social care costs have prompted a critical look at the way clinical services are managed and delivered. In the last 20 years, there have been a significant change in assessing the performance and measuring the outcome of services. Clinical service provided are expected to be efficient, effective, and cost-effective. Where once only performance outcome data related to service efficiency were required. For example, the number of contacts produced per month, waiting time, did not attend, or DNA rate. Now evidence of clinical outcome related to effective of the service and economic outcome related to cost-effective of service is demand. So to meet this demand, occupational therapists must continue to innovate the structure and processes of service delivery to improve the service efficiency and to conduct research to demonstrate the effectiveness and cost-effectiveness of OT services. In this lecture, I will briefly review the historical and current perspective outcome in service delivery. First in the health service, and then focus on within the OT profession. After that, I will discuss the interdependent relationship between performance, clinical, and economic outcome in service delivery. Then I will share example of strategy based on practice-based and research-based evidence to optimize performance outcome related to efficiency of the service, clinical outcome related to effectiveness of the service, economic outcome related to cost-effective of the service. At the end of this lecture, I will propose what we need to focus on in service development, clinical practice, and research. So let's first look at historical perspective of outcome in the health service. In the 1960s, Dr. Billions conceptualized the quality of a clinical service using the triad of structure, process, and outcome of care. Structure include the physical facility, equipment, and human resources, as well as organizational features such as staff training and payment methods. Process refer to the actions, activity, and procedure that occur between service provider and the clients. Outcome refer to the change in the client health status that can be attributed to a clinical service provided and is the result of structure and process of service. Tava et al. In 1989 proposed to expand the domain of outcome by adding client satisfaction and economic effect. So he formed the initial framework for optimizing clinical outcome that include treatment effectiveness and client satisfaction, and economic outcome related to cost effectiveness of the service by improving the structure and process of service that related to performance outcome, efficiency of the service. Since then, there are different quality improvement frameworks developed in the last 40 years. Some of these frameworks have been used in the health and local authority services. For example, the McKinsey 7S, Maxwell 6, Six Sigma, Total Quality Management, Balance Scorecard, the Clinical Government Framework introduced in Lectures in 1997, and Continuing Quality Improvement. This framework set a foundation to improve the quality and safety of service delivery. However, mechanisms to assess the performance and measure outcome of service need to be in place. There are different developments in the last 20 years. I will highlight two important developments. In 1999, the NHS Performance Assessment Framework was introduced to assess the performance of different clinical services. This framework is based on balanced scorecard. Within this framework, there are 6 areas of performance: health improvement, fair access to service, effective delivery of appropriate healthcare, efficiency, patient and carer experience, health outcome or NHS care. And then in 2010, the NHS outcome framework was developed after consultation with NHS provider. This outcome framework focuses on improving health and reducing health inequality. So based on this outcome framework, commissioner from clinical commissioning group, another commissioning body, use a set of performance indicator and key performance indicator to measure the performance and clinical outcome of clinical services. For example, waiting time, DNA rate, treatment outcome individual client satisfaction rating, etc. Within the OT practice, achieving performance, clinical and economic outcomes are important goals in service delivery. For example, evaluation of the effectiveness of OT intervention is identified as one of the 8 research priorities set by the Welfare Relation OT developed in 2016. The Welfare Relation also produced the CREST Quality Evaluation Strategy 2 in 2020. There are 7 quality dimensions from the perspective of structure, process, and outcome. The 7 dimensions are appropriateness, sustainability, accessibility, efficiency, effectiveness, person-centeredness, and safety. The Welfare Relation also produced these 2 on economic evaluation in 2021. Is the resources for OT to evaluate the cost effectiveness of service provided. And then in 2021, the Royal College of OT developed the top 10 research priority in the UK. Clinical effectiveness and cost effectiveness of OT service are part of the top 10 research priority. In the new professional standard for OT practice, conduct, and ethics, there are 8 outcomes stated in section 4.6 on outcomes, quality, value, and effectiveness. These are the 8 outcome statements. Outcome statement 1 to 4 are related to clinical outcome. Statement 5 and 6 related to performance outcome. Statement 7 related to economic outcome. While statement 8 is the composite of all the 3 outcomes together. So it is good to see that the OT profession does not only focus on clinical outcome, but also emphasize the importance of performance and economic outcome in service delivery. When evaluating the outcome of service, performance outcome are related to efficiency of the service, clinical outcome are related to effectiveness of the service, economic outcome related to cost effectiveness of the service. These 3 outcomes are interdependent with each other. It is important to examine this relationship and explore strategy that can be used to optimize these 3 outcomes in service delivery. So let's first look at performance outcome related to efficiency of the service. Performance outcome, sometimes called system outcomes, are related to the structure and the process of the service. It demonstrates the efficiency of the service. Efficiency is the optimal use of resources to yield maximum benefit. So it focuses on avoiding wastage and maximizing the use of resources, time, and effort in service delivery. Clinical outcomes include treatment effectiveness and client satisfaction of the treatment provided. It is underpinned by the efficiency of the service. Okay, let's look at relationship between efficiency and effectiveness. Both efficiency and effectiveness are important components for measuring the quality of a service. Being efficient is about doing things right, while being effective is about doing the right things. So to achieve clinical outcomes, the established structure and processes of service delivery must run like a well-oiled machine. So that means having effective treatment is not enough if you do not have efficient service to deliver the treatment, to measure outcome, and to calculate the cost and input involved. So let's look at economic outcome related to cost effectiveness of the service. To achieve cost effectiveness, a service needs to establish efficient structure and operational procedure to deliver the identified effective treatment. So that means economic outcome is dependent on performance and clinical outcome and validated by economic evaluation that I'm going to talk about later. Besides these three outcomes, outcome of other quality dimensions need to be considered. For example, appropriateness, accessibility, sustainability, safety, etc. To optimize this outcome in service delivery, effective leadership, the application of service improvement strategy, and high quality research are important practice factors to be considered. So let's look at leadership. The concept of leadership is complex and multidimensional. There are different leadership theory and style. For example, coaching, visionary, and transformational leadership. Most leaders adopt a combination of style to achieve goals at different times and in different situations. There are different soft skills to be a successful leader. For example, to be able to communicate effectively, organize information systematically, build relationships, inspire others, think strategically, and able to lead change. However, to be a successful leader, you also need a hard skill or the technical knowledge in different areas of improvement. For example, excellency in clinical practice, research and evidence-based practice, staff development, service redesign, and financial management, etc. So leading service improvement is a practical task. If you don't have the tools, you cannot do the job. Central in the whole service improvement process is research. Han et al. In 2022, in the editorial of a special issue of the American OT Journal on health service research, they suggest that it is timely to conduct health service research to identify the most effective way to organize and deliver high quality care to maximize health outcome and to demonstrate the value of occupational therapy. This message is consistent with the concept of performance, clinical, and economic outcomes discussed in this lecture. DeLong et al. In 2021 in the British Journal OT and Beckman et al. 2022 in the Canadian Journal OT advocate the importance of patient and public involvement in the whole research process. So therefore, the collaboration with manager, clinician, researcher, health economist, with patient and public involvement is important to highlight the need, obtain funding, and implement research to identify the factors which contribute to the achievement of these three outcomes. An effective manager will apply the range of service improvement strategy to optimize performance, clinical, and economic outcome. So I will share with you example strategy that based on practice-based and research-based evidence to outcome. So let's look at strategy to optimize performance outcome related to efficiency of the service. I select 5 areas for discussion: workforce planning and staff development, using lean thinking service improvement strategy, interagency collaboration, stakeholder and service user involvement, structure and the mode of service delivery. So let's look at workforce planning and staff development. Anastasia et al. In 2015, they say that internationally, successful organizations have been those that consider the workforce as the most important asset to promote service quality and customer satisfaction. Personally, I consider this area is the most important strategy, as you need a good team of staff to develop and deliver an efficient, effective, and cost-effective service. For workforce planning, the most important factor are related to having skilled mix of staff with appropriate level of competency. That means having the right person doing the right job. Opportunity for career progression. That means you need to have a structured staff, a different banding or grading, so staff have the opportunity to move up. It is also a good means to keep good staff. Clearly define role and responsibility of all staff, so that all staff know what they're expected to do and how to contribute to the whole service. Define work role and productivity. For example, how many contacts should be produced per week. It serves as a means to calculate the capacity of a service. Our visionary manager will put staff development as one of the top agenda, will create structure of supervision and support. That means all the staff will have a named supervisor and schedule of individual treatment supervision session. System appraisal and personal development plan. All staff will have annual appraisal and produce PDP with defined objective for professional development. Empower all staff to be involved in various service improvement activity, so the whole team work together to improve the efficiency and effectiveness of the service. The Career Development Framework published by the Royal College OT in 2021 is an excellent resource for staff development. So it provides structure with a set of guiding principles to inform career, learning, and workforce development within the OT profession. Managers also use management research evidence to enhance service efficiency and client satisfaction. For example, West et al. In 2011 identified that one of the main factors affect service efficiency and client satisfaction is the satisfaction of staff working in NHS. There are different studies published in the last few years by analyzing data from the annual NHS staff survey. I summarize the findings from these three studies. The factors are reduce work pressure, recognize good work and value staff, target wages increase with career progression, accommodate the needs of a diverse workforce, prevent discrimination, effective communication engagement, establish staff bank, and CPD. So managers should consider this job satisfaction factor in staff development. So the overall aim of staff development is to develop a workforce that is contented, devoted, and fit for purpose to deliver an efficient, effective, and cost-effective service. So if you don't have a good team of staff, you cannot deliver efficient service, even the effective intervention available. The second is the use of lean thinking service improvement strategy. Lean thinking first developed from the Toyota production system in 1928, have been increasingly applied to health service to improve the quality of patient care. I first encountered lean thinking through literature in early 2000. It is a way to streamline the patient journey and making it safer by helping staff to eliminate all kinds of waste and to treat more patients with existing resources. In 2007, I attended 2 workshops on lean thinking when I attended the International Conference on Health Service Management Improvement at Barcelona in Spain. It started my journey to pursue lean thinking for service improvement. A lean organization realized that improving quality and safety results in more efficient and cost-effective care. So based on lean thinking, the NHS Institute for Innovation Improvement published the Productive Community Hospital Program in 2009, which resulted in staff having 20% extra time to spend with patients. So it has been proven that this program improves efficiency and productivity of service. The Institute also developed a productive community service program in December 2009 and implemented the program in 2010 with the whole staff team. The program is the whole management system with tools and methods to improve efficiency of the service. So to improve efficiency of the service, OT manager and clinician need to develop lean eye for service improvement. The third area is about interagency collaboration. Interagency collaboration is important to coordinate services, minimize the need for referral, and avoid duplication. The two aspects of interagency collaboration: first, integration of OT services in different agencies, for example, OT service from health, education, and social care. Second aspect would be working collaboratively with other services and agencies. So armed with knowledge in service improvement, are able to collaborate with key stakeholders from different agencies to develop the service and manage into a fully integrated and multi-agency fund OT service for children. The service have funding from multiple sources, with 40% of budget from NHS and 60% of budget from education, social care, other services, and projects. There are many benefits in having an integrated service. There's a single point of referral. All the children referred will be processed through unified and integrated clinical pathways. Each child referred to the service will only have one OT at one time, versus 2 or 3 or even 3 OT from different agencies if the child is living in a different area. The therapy will be able to deliver a holistic care plan for children, and the work will not be artificially separated into different parts. Parents do not need to deal with different OT from different agencies at different time, so it facilitates continuity of care and provides seamless service. The service was shortlisted as the finalist for the 2014 Health Service Journal Award. The fourth area about involving stakeholder and service user in service development. Most of the grade in 2012 stated to determine whether a service is comprehensive, coordinated, and effective, crime perception should be considered. So therefore, the involvement of service user and stakeholder to shape the service is essential to improve the service. The involvement can be facilitated by setting up service user group and stakeholder forum, networking with voluntary service representing service user, or using regular survey to obtain feedback. The fifth area to improve the efficiency of the service is about establishing structure and model service delivery. So manager need to create an efficient structure and model service delivery in order to maximize the ratio of time spent on direct client contact versus time spent on other supporting activity, example like documentation, meeting, or traveling time. There are many components to be considered in developing a good structure of the service. For example, having a set of policy and procedure to guide practice. Have a weekly work plan for all the staff so they know where they are and what they are doing. Adopt the conceptual model of practice. For example, in the service I managed before, we use the model of PEO. Having clinical pathway with clinically defined referral procedure and care package for different care group requirements. It has been proven that the implementation of clinical pathway helps to reduce variability in clinical practice and improve outcomes. In the UK, different modes of service delivery have been developed in OT, from direct service delivery based on individual client to multi-team model of service delivery. In 2010, I adopted a 3-team model to deliver a school-based OT service to special and mainstream school. This model emphasizes early intervention and address student learning needs through universal whole-school-based, target classroom-based, intensive individual-based intervention. Through this model, I was able to secure funding from education department, special and mainstream school for over 10 full-time posts to deliver school-based OT service to all school-age children refer to the service. Now let's look at strategy to optimize clinical outcome effectively on the service. So to optimize clinical outcome, it is important to consider different processes in service delivery that help to optimize clinical outcome. I select 4 areas for discussion: evidence-based practice, person-centered and family-centered care approach in service delivery, setting goals for measuring treatment outcomes, selection and use outcome measure. Evidence-based practice provides framework to guide clinical reasoning and decision-making in OT practice. The current concept consists of different components, so to optimize clinical outcome, it is essential to apply and integrate the best research evidence, consider opinion from clinical experts and clinicians' own knowledge, and take into account the client's value, preference, and circumstance of treatment provided, and also consider the practice context, various political, economic, social, cultural, technological, legal, and environmental factors. So that means clinicians need to be able to critically appraise published research studies, assimilate rated observation from clinical experience, collaborate with researchers, and apply research data to optimize clinical outcomes. The second area to improve clinical outcome is to deliver service underpinned by the philosophy of person-centered and family-centered care practice. Person-centered care supports people to develop the knowledge, skill, and confidence they need to be more effectively managed and make informed decisions about their own health and healthcare. There's a growing evidence that person-centered care can improve a range of factors, including patient experience, care quality, and health outcome. It has long been recognized in family-centered care practice that the outcome of the child's development is highly influenced by the caregiving environment. So to improve clinical outcome, therapy needs to empower parents to become an equal team member and involved in the whole treatment process. Both person-centered and family-centered care practice can be facilitated by using service delivering approach like occupational performance coaching, OPC, developed by a team of Australian OT, which was initially used in the children's service, now can also be used in the adult service. The third area to optimize clinical outcome is about setting goals for measuring treatment outcome. So it is important to set SMART goals as a means to measure the outcome of treatment. SMART stands for specific, measurable, attainable, relevant, and time-bound. In occupation-based practice, there are several best practice factors to be considered when setting treatment goals in order to optimize clinical outcome. The first factor is about participation goal. Participation is one of the most significant outcomes of medical, rehabilitation, social, and educational input. Peter Riad and al. In 2019, they say that meaningful participation goals provide powerful motivation. We can promote individual action and persistency toward goal pursuit. The concept of participation in OT is consistent with the concept of participation articulated in the International Classification of Functioning, Disability, and Health model in both adult and children model. The ICM model fits well with the OT philosophy and different conceptual model practice. The model provides conceptual orientation for setting participation goal, the end, and applying various treatment method, the means, to address impairment in body function and structure, reduce limitation in activity, promote participation in different functional activity, with consideration of the health condition, environmental factor, and also personal factor. The third factor considered in setting goals is about teamwork and collaborative goal setting process. Goal setting through teamwork is essential to achieving the clinical outcome. Goal setting that's truly collaborative will drive motivation, engagement, self-advocacy, meaningful involvement, and enhance outcome. So therefore, goal must be established in conjunction with the client, parent or carer, and all professionals involved, so that the goals are meaningful and important to the client and family. The fourth area to optimize clinical outcome is the selection and use of outcome measure. To ascertain the defined treatment goal have been achieved, it is important to select and apply quantitative and qualitative outcome measure. Quantitative, sometimes we call hard outcome measure, provide information on how much the defined outcome have been achieved in form of numerical data, for example, using long-reference standardized measure. Qualitative soft outcome measure provide information on how well the outcome have been achieved in form of descriptive information. For example, using self-evaluation by client satisfaction survey. This figure illustrates a continuum of quantitative and qualitative outcome measure or method. For example, quantitative hard outcome measure, we got client or child-centered outcome measure, family-centered outcome measure, participation, functional developmental skill outcome measure, soft or qualitative outcome measure like survey user experience survey, cell rating analog scale. It is good practice to use a combination of hard and soft outcome measure to capture all aspects of the client problem from multiple perspectives. So now let's look at strategy to optimize economic outcome related to the cost effective of the service. With the current financial climate, occupational therapy needs urgently to demonstrate cost effectively of the service in comparison with other interventions. The four areas to be considered: a matrix the cost and effectiveness, costing information in health and social care available, calculating unit cost and productivity of a clinical service, and also economic evaluation to evaluate the cost effectiveness of the service. So this figure illustrates the matrix of cost and effectiveness, where intervention that require high cost and low cost have low effectiveness and high effectiveness. The ideal option would be number 4, an intervention that's highly effective but at the lowest cost. A strategy to optimize clinical effectiveness had already been discussed. I will focus on discussing the cost involved. Let's look at costing information in health and social care. In 2015, a single national cost collection was established to replace the reference score we use in NHS from 2021. The aim was to drive the transition to patient-level costing for continuing improvement in the NHS, and this in turn will mean better outcome for people using the service. The Personal Social Service Research Unit of the University of Kent has published any report on unit cost of health and social care since 1992. Unfortunately, unit cost published in this report are not always applicable to a particular OT service, as specific context, staffing, unique way to using resources need to be considered when calculating unit cost. So in preparing for welcome commissioning introduced in NHS in 2007, I was asked by the senior management of the Ealing Primary Care Trust to develop a tool to be used by all community service to calculate unit cost, caseload, and productivity. This figure illustrates a schematic structure of the step for calculating unit cost, caseload, and productivity of a clinical service. As there's not enough time to go through all the steps in this structure, I will use calculation step 1 on duty hour and step 2, clinical input hour, to demonstrate the importance of optimizing service efficiency to reduce unit cost. So step 1, calculating on duty hour. On duty hour are the hours in the year a staff member is expected to be available for work after deducting annual leave and other leave from the contract hour. So let's look at the calculation step. Step 1A, contract hour. In NHS, revert 77.5 hours per week, so 52 hours. So the contract hour is 1,950 hours. Step 1B, less fixed hour, annually minimum 27 days, plus 8 bank holiday, equivalent to 7 weeks. So we take away 263 hours. And then step 1C, less study leave for both strategy and external training courses. Say, for example, minimum 2 weeks. So we take away 75 hours. And step 1C, less available leave, including sick leave and other leave like compassionate leave. We have to exclude long-term sick leave and maternity leave. We have to do the calculation separate. You can also refer back to data in previous year. For example, minimum 2 weeks, so we take away 75 hours. So step 1C, the maximum available on duty hour. These are the hours per year a staff member available for work. So the maximum on duty hour in the year is 1,537 hours. So let's look at step 2, calculating clinical input hour. Clinical input hour are the hours in the year a staff member is expected to be available for doing direct client contact, both face-to-face or non-face-to-face, for example, telephone consultation. So let's go through the steps. Step 2A on duty hour, we've done the calculation already, is the maximum hour per year a staff available for work. So we got 1,537 hours from the previous calculation. And then step 2B, clinical input hour. The calculation of clinical input hour is based on the percentage of on-duty hour available for a therapist to do direct client contact after detecting time spent on other supporting activity, for example, documentation, traveling, team meeting, supervision. Say, for example, if the ratio of time spent on direct client contact and other supporting activity is 40% versus 60%, then time available for full-time OT to do direct client contact per year is 40% of 1,537 hours. We got 615 hours. So in order to do the calculation, each service needs to have information on the ratio of time spent on direct client contact and other supporting activity. You can now get data from the information system. You just enter those information in the system, or if not, you can conduct a time and motion studies for 1 or 2 months to get the data on the ratio. Then how to reduce cost per contact. So if you use various service improvement strategies I mentioned, like lean thinking, to optimize the efficiency of the service, to increase the ratio of time spent on direct client contact, to produce more clinical input hour, as a result, to reduce the cost per contact. So let's look at some example. Example 1, the ratio of direct client contact versus other supporting activity, 40% versus 60%, actually is the one we looked at before. You got 615 clinical input hour. Example 2, if you improve the efficiency, increase the ratio to 50% over 50%. So you increase the clinical input hour to 768. And then example 3, improve efficiency, increase ratio even better this time, 60% versus 40%. So you increase the number of clinical input hour to 922. So with more clinical input hour available, you produce more contact, the cost per contact will be reduced. The last area look into how to optimize economic outcome is about conducting economic evaluation. Economic evaluation of OT, a systematic method to examine the impact of OT in relation to the financial cost of providing a service. Economic evaluation involves comparative analysis, for example, the cost of intervention A and B with the clinical outcome of intervention A and B. There are multiple forms of economic evaluation with cost-effectiveness analysis, the most common one. Watson, 2002, and Drummond et al., 2015, suggest that it is important to establish the clinical effectiveness of the intervention before assessment of cost. However, Morrow and Simpson, 2022, argue that cost-effective analysis should be added to clinical trial to evaluate the treatment effectiveness, cost, and cost effectiveness at the same time. So no matter which order to follow, cost represents an integral part of the whole evaluation process. Unfortunately, in a systematic review conducted by Green and Lambert in 2016, published in the British Journal OT, they found that the current low number and variable quality of health economic evaluation in OT are largely insufficient to inform resource allocation decision. Therefore, Valerie and David in 2021 advocate greater emphasis on being research active and incorporating information on cost and clinical effectiveness, as well as other societal care outcomes. So to conclude this lecture, occupational therapy must rise to a new level of sophistication in demonstrating that the services we provide are efficient, effective, and cost-effective. To achieve this, the interdependent relationship between performance, clinical, and economic outcome in service delivery, underpinned by strong leadership, the use of various service improvement strategy, and collaborative research is an important practice factor to be considered by all occupational therapy pursuing service improvement. So there are three take-home messages. First message, in service development, managers involve all clinical support and administrative staff in service improvement activity to improve the efficiency of service, to produce better performance outcome as a basis to achieve better clinical and economic outcomes by examining and applying practice-based and research-based evidence. For example, consider job satisfaction factor in staff development, collaborate with other agencies, involve service user in service development, and develop a good structure and model of service delivery. Second message, in clinical practice, all the clinicians and researchers should collaborate to conduct research with patient and public involvement to validate interventions that are not only effective, but also affordable, that means does not require a lot of resources, deliverable, that means does not require highly specialized equipment or staff have to go through expensive training, sustainable, can be provided year by year, and to be delivered in the person or family-centered way, and with measurable outcome focus on promoting the client participation in different functional activity. Third message, manager, clinician, researcher, and health economists should collaborate to conduct economic evaluation to demonstrate the cost effectiveness of OT services. So to end this lecture, I would like to use the 8 quality rights proposed by Mercer degree in 2012 as the benchmark statement for our service improvement. So it states that providing the right healthcare services in the right way, in the right place, at the right time, by the right provider, to the right individual, for the right price, to get the right results. So if we help to achieve the Royal College OT vision, people everywhere value the life-changing power of occupational therapy. I would like to use this opportunity to acknowledge different group of people. First, to all the staff work with me in my service before, they help to develop and deliver efficient, effective, and cost-effective service. And then to health colleague, another colleague from education, social care, and volunteer agency, thank for the support and collaboration to help to develop the service to be fully integrated in multi-agency fund service for children. And to children, a parent I've worked with in the last 40 years, they help to develop my clinical skill and improve the process of service delivery. And then to OT, another health and educational professional who attend all my courses within UK and all over the world, their appreciation and support motivate me to develop and deliver more courses. And lastly, to all the author or all the references and picture I use in this lecture. Thank you.
Well, thank you so much, Dr. Chu. Well, that was excellent. I thoroughly enjoyed that. It was such a detailed and comprehensive approach to the history and the currentness of this incredibly important topic. So I'm going to try now there've been lots of questions coming in from the audience. So you are going to join me on the stage, I think, or on the virtual stage. And I'm going to ask you some of those questions. And you've obviously got our audience thinking this evening, Sidney, because there's been some really quite complex questions coming in. But I'm going to start you off with one that very much homes in on your area of expertise, which is children's services. So I'm not sure who this has come from, but the question is, do you think it's possible for children with long-term conditions who have had such an integrated holistic service to continue having that seamless care when they become adults? So that's part one of the question. So I suppose it's very much, Sidney, around that transition that we all struggle with, that people often fall, don't they, between the gaps when they're moving from service. So at this point, do you have any thoughts or comments on that question about that transition from children's services to adult services?
That's always a big gap in service delivery. So in my experience, what we need to do as a service provider is prepare the child or the young person, and especially the family also prepare for a transition. And also establish good link between children's service and adult service. Luckily, at one point, I managed both children and adult service in OT. So the transition will be more smooth and running. But I know in some other area, they're not same management structure. So liaison is very important. But bear in mind also, it's not only between OT to OT, but also other agencies involved. So that's why if you work in an integrated manner, linked to other agencies, especially education, and also social care and other voluntary service are very important to support individual transition from children to adult service, and also give guidance and support. And luckily, the new Children Family Act 2014, so they extend the age range to 25. So it's not the traditional age of children as such. So in a way, if someone have the multi-agency assessment, have the education and healthcare plan, so we have the statutory duty to help them transition from the traditional children's service to the age of 25. So it's a matter of getting the funding to support them. So luckily, the survey I managed before, we got a lot of funding from education. So we're able to provide those services in transition.
And another incredibly important reason why we need to show our services are cost effective and efficient. And the more you can do that to any commissioners, you're more likely to get the funding for those transitional services. There was a supplementary question asked by this person, and I'm sorry, I don't know who you are. I'm very sorry, I'm having the questions come through in a different platform. So the supplementary question, and I think you started to answer it, is how can adult services learn from a model as such as you created?
How?
How?
I think the main thing will be, first, you really have to establish yourself first to be someone that people recognize your skill and knowledge. So as a result, what you say to other people carry more weight. So that's how I start in my job before. So when I first start work in that area, when I first moved to UK in 1987, when the children's service is quite small at that time, it's only 3 OT there. So no one really knows what OT can do. So in one of the team meeting in the child development team, there's a young girl, 3 years old with autism, a major problem, sleeping pattern, create a lot of problem with the parents and affecting the whole family. And within the whole team, no one can solve the problem for a child. So as a newly arrived OT and young OT at that time, so I volunteered myself to see what I can support the family. So I done a home visit and look at the home environment. A child autism, she also has sensory defensiveness. When I look at the bedroom, and I can see for a girl bedroom, what will you see? Pink color, bright color everywhere, toys scattered around, and too much stimulation. So as a result, my parents modify the home environment, reduce the sensory component, and also introduce a lot of sensory, what we call now sensory modulation activity, and also introduce different behavior approach. And the parent really implement well with the strategy. After 2 weeks, the situation improved. So when we get back to the team, discuss about what happened to that girl, everyone was so amazed what I can achieve. As a result, all the children, autism, all refer to OT. Yeah. So once you can establish yourself and recognize to be a skillful person, know what you're doing, people will listen to you, and you reach out to people. I involved with so many other people, not only about health agency, I work with our volunteer sector also. I think the main thing would be you reach out to people, collaborate, work together, share resources, and also have same vision. One of the things I always say to people, the reason we're here is the client that need our support. So that's why we have to work together.
Yeah, fantastic. Thank you, Sidney. So I have a slightly different question now, taking us down a slightly different path. This has come from Sharon. I don't know where Sharon is in the UK or beyond. We know tonight we have many people joining us from across the world. But I take it they are in the UK because they're asking about UK services. And the question is, how can they gain opportunities to publish their outcomes in academic journals? Because I think what was very evident in your lecture, Sidney, is that you've published throughout your career. So when you have done something and you've developed it, you've published. So this is a cry for help, really, of opportunities to support publishing outcomes in academic journals. Have you got any thoughts on that?
I think start with something simple first. Rather aim at research journal to be published more practice-based article to start with, so that in a way they're less challenging, less demanding than the research article. Say our OT news, we're good first platform to start publication first. Once you build your writing skill, publish something a bit more less demanding, like practice-based article rather than research-based with all the data and things like that. Build your confidence. And let's start with some research and more easy to do, like single case studies. Rather aim at more high level, like randomized control trial or economic evaluation. Those things very high level research. So start with something that's simple, and more important, get a good mentor, and also collaborate with other people. Yeah.
Yes, totally, Sidney. I think that's a fantastic answer. I think that it is better other people, isn't it, and not feeling that you're on your own, and that you have got other people with you, and that mentorship is really important.
Further collaborate between researcher and clinician. I think that bridge need to be really narrowed down. We should work together. We got a lot of things that we are doing in the field. Some researchers may not aware about what we are facing and the demand that we are facing on everyday practice.
Yes. I have another question here coming in from a senior lecturer, and sort of on the lines of going back to your matrix, really, and the layers of different data that you're collecting. What do you think the role of big data might have in helping health economic analysis?
Both. The data I mentioned about, I think we refer back to the last few lines, calculating unit cost. Those are very individualized service related. And what we need to do more in our profession will be have more OT have the skill to learn how to calculate unit cost. Because one of the main thing about the shortcoming about doing economic evaluation is not only about establish the effectiveness of the treatment, but also calculate the cost involved.
Right.
So you don't know how to calculate the cost, you cannot do the economic evaluation. So that's why I saw the last two slides and few lines about calculate on duty hour and also clinical input hour allowed you to calculate unit cost. So when you try to calculate a care package, if a care package requires, say, 20 clinical input hour, and each hour costs that much, then you can give costing for that care package.
Yeah, thank you for that, Sidney, because that kind of, her second question was very much about, you know, how as an occupational therapist can we make use of that big data to improve the OT service or practice? So kind of what you're saying is you need to know what your own costs are within the service you have and the unit costs and what they are before you can then look to the bigger data to say, is my service in line with that? Is that actually helping me? So I think that's quite an interesting one, isn't it? We've almost got to come back to who you are as an individual occupational therapist, what you do, and there how your service fits in with that.
Yeah, I think the whole field of economic evaluation is still developing, not only in OT, but in other fields as well. I think collaboration is very important in that sense. So first thing I think we do is sort out in-house first, so we know how to calculate ourselves, yeah. and then try to compare our unit cost with other people.
Yeah, yeah.
And before you calculate unit cost, actually, it's very important. The main message I want to say to people is to improve the efficiency of the service. As a result, you can reduce the cost.
Yeah.
No point just calculate the cost if you're too expensive, so you're not comparable. Yeah. We don't have a competition.
Our 10 minutes is nearly up, Sidney. I cannot believe it, but there is one final question I would like to ask, and then I'll just keep my concluding remarks shorter so that we've got more time, because this has come through from both Ian, who's an apprentice occupational therapist on a degree course at the moment, and slightly asked in a different way from Sarah, who's an associate professor. So similar question from people at different ends of their occupational therapy journey. And it's very much about going back to your unit cost, you know, what's included and what isn't included, which documentation is in and isn't in. You know, if you're doing a risk assessment or you're doing something that's not your normal outcome measure, how do you calculate that against the time measure? But then the question from Sarah took that further and said, do you think such considerations ought to be embedded in the teaching of evidence-based occupational therapy interventions on all pre-registration programs? Or is it something we should be picking up as CPD as once we have qualified?
I think I answered in the backward way about whether included in undergraduate training. I think the concept about efficiency, effectiveness, and cost effectiveness should be mentioned in undergraduate course. So people know about the relationship between the three factors. So they're not only learning about effectiveness of the treatment provided, we also consider about you need to have an efficient service to deliver the effective treatment. Okay. Yeah. And about calculating unit costs, and there will be an article published in the British Journal later about my lecture. There will be reference about that flow chart that I saw in the presentation before, about how to calculate on duty hour, clinical input hour, and then unit cost calculation. The reference will be there, but there won't be detail there. So I can briefly mention about unit cost calculation. Once you have the unit cost, clinical input hour, what you need to do, calculate the amount of money involved in that staff providing the service, and the proportion of time for management, your budget proportion of time, and don't forget to add 15% of overhead into that total costing, and then divide by the number of clinical input hours, you get a unit cost.
Right. Sidney, thank you so much. There have been so many questions coming through. I haven't done them justice at all. In fact, you've just stimulated so much thoughts from people, and I think so it sort of lends to me really to sort of bring tonight's lecture to a close and actually just say a few words, if you'll elect me. I just found that absolutely fascinating. It really took us back through the history of how service evaluations and cost effectiveness has developed over the years. And Sidney really clearly led us through how he developed the model that he developed into the Integrated Children's Service. And I just felt that it was such a detailed and comprehensive lecture. I think, as you say, Sidney, your lecture will be published in the British Journal of Occupational Therapy. And I think it's one that I want to read and reflect on again, but it's really given us food for thought. This is such an important topic and such an important area for occupational therapists that we really have to think about what we do, why we do it, and the cost that takes, and are we giving the best service to the people that we're working with? You know, at the end of the day, it's about those people, isn't it? It's about offering the best occupational therapy we can at the most cost-effective way. And we have to learn how to understand that cost effectiveness. And I think you answered it beautifully, that this is a combination of embedding this into undergraduate programs, as well as a qualified occupational therapist taking up CPD opportunities and actually learning how we really do evaluate the effectiveness of the services that we provide. I loved your diagrams because they really show that this isn't linear. This is complex, it's a matrix. There are many, many people involved. And I think there were three particular words, if I can have one phrase as a word, but three phrases then that really came to mind for me. And one was collaboration. Throughout your lecture, you talked about collaboration. The second was meaningful involvement. So not just from the therapist's point of view, from a manager's point of view, from a researcher's, from a stakeholder, from a patient's point of view. And then the third one for me was participation, that we all are participants in occupational therapy here. Even as the occupational therapy, you are participating within that intervention. So I think that those came across really strongly to me, and it would be interesting if they still come across strongly to me, Sidney, when I read the written version of your lecture as well, and see if they're still coming out for me. So I thank you very much for the lecture tonight. And on behalf of the Royal College, with the Elizabeth Casson Trust, we will be sending you, Sidney, a special token to acknowledge you joining the esteemed group of Elizabeth Casson Memorial Lecturers. And then just a reminder to all of our audience, we will be sharing the recording of Dr. Chu's lecture on our website. And as you've already heard from Dr. Chu, there will be full written details and the full reference list of the article published in the British Journal of Occupational Therapy. And again, to our audience, do use our self-directed learning toolkit to support you to reflect on the specific points raised in this lecture. And looking at the questions I didn't get to, there are hundreds of questions that your lecture has raised. So I encourage you to use that toolkit to encourage further and identify further actions. This will also be on the website and of course is available for everybody to access. The 2023 Casson lecture will take place in April next year. And don't forget, please, to nominate a colleague who has made or is making a significant contribution to our profession to give next year's lecture. So, you know, if you're interested in nominating something, please go to the Royal College's website for more information. It's now time for me to say thank you for joining us this evening. There were over 2,000 people, or nearly 2,000 people registered for the event this evening. And a significant number of those 2,000 actually joined us this evening, Sidney. So one of the benefits of a virtual is you don't get all those people looking at you, but you have had them looking at you virtually. So thank you for all of our audience that have joined us from, and as I said, from around the world. I know there are colleagues that have joined us from North America, from Singapore, from Hong Kong. So you are more than welcome, and we're delighted you were able to join us this evening. So without further ado, I wish you all a very good night and thank you again, Dr. Chu.